Might start in one moment and then I'll introduce you, Liz.
Hello.
Hello, welcome everyone. Welcome. Okay, thanks everyone for joining. I'll just ask you to please mute yourself. I might get started in just a moment because I think we do want to give all our fantastic speakers the best possible chance to be showcasing their work with us today. So welcome and thank you so much for joining us at this inaugural webinar for the PoCoG End of Life Care Special Interest Group. My name is Ursula Sansom-Daly. I'm a clinical psychologist at Sydney Youth Cancer Service and a senior research fellow at UNSW. And I'm thrilled to be here with you all today. I want to start by acknowledging that we're all sitting and meeting on lands that are a traditional country of traditional custodians. And I'm personally sitting on the traditional country of the Gadigal people of the Eora Nation. So I'd like to pay my respect to elders past, present, and extend that respect to any Indigenous people who are present today. So in joining us today, we're thrilled to be able to host this webinar. I think earlier in the year or late last year when we first formed this SIG, we were of course dreaming of wonderful face-to-face events where we might be able to connect and collaborate in person, but nevertheless we shall forge ahead. Really just as a brief plug for the PoCoG End of Life Special Interest Group. It was just formed last year, chaired by Professor Liz Lobb, who we'll hear from in a moment, and myself. And really the intent of the Special Interest Group is quite simple, which is to connect interested and like-minded researchers and clinicians with an interest and a focus on end-of-life care research and clinical practice. And really we see today's event as one of those stepping stones to help us forge further collaborations and make some wonderful connections. And you know, I'm really thrilled in meeting all of our speakers today that not only are our topics really diverse and interesting, but we've also got such a fabulous representation of people from all the way from just starting a PhD through to our very most esteemed professors. So that's really exciting. So I think that's a good moment for me to introduce our keynote speaker today and our chair of the SIG herself, Professor Liz Lobb, who many of you will know well, but for those of you who don't, Liz is the Professor of Palliative Care based at Calvary Healthcare in Kogarah, and she's the chair of the Palliative and End of Life Care Research Institute, and she's got a wealth of knowledge, having worked as a bereavement counsellor clinically for over 20 or 25 years, and also has several decades of research experience as a behavioural scientist, really establishing international collaborations and leading the space in kind of palliative care, bereavement and end-of-life communication. So Liz is going to speak to us today a little bit about end-of-life and bereavement care in this sort of world of COVID-19. So welcome Liz, and feel free to share your slides when you're ready.
Thanks so much, Ursula, and thank you very much for that warm introduction, and welcome everybody. I'm really delighted to have so many of you here today. So I'm going to put my slides up. Please let me know that they're showing full screen. Are we doing okay?
They haven't quite loaded yet, but they might still be loading.
Okay. Still happening? I have it on my screen here. Do you have it up where we are?
No, not quite yet.
Okay.
You'll need to share the screen, Liz.
Yes, I've done that. Let me just take it off again and I'll share the screen again. I had this problem once before, so let's hope that it works again. How are we going now?
Yeah.
Now I want to get it up to full screen. Are we okay?
Yes.
Yes.
All good.
Perfect. Okay, so that's wonderful. And I'm just going to move that there so I've got a better image of what we've got up. So thank you so much for the opportunity to talk today about end of life and bereavement care in this very extraordinary time of COVID. The picture that we've got on the screen was Nature's pick of science images pretty much at the height of the COVID epidemic. And it shows particles of the coronavirus that causes COVID-19. And researchers isolated these virus particles from the very first person who was diagnosed in the United States, which is really quite extraordinary, because if you look at the figures today, there are currently 7.5 million people who have been diagnosed, but also 207,000 people who have died. And this is really significant, I think, because much of the literature that's coming out, much of what we're seeing is based on this fairly high death toll in America. And of course, in Australia, we ourselves have 27,000 cases and 886 deaths, and not in any way meant to minimize the impact of those deaths and those diagnoses on the families involved. But I just thought that this image was a good introduction to the presentation today, because many people who have been bereaved in the time of COVID, and a lot of what I'm looking at today is people who have had experience, who have had a bereavement in January, because we're acknowledging that if there was a death in January, that by March, April, which is when we pretty much went into the restrictions for COVID, these people were very much in the early stages of their grieving. And so I'm really looking at this whole process of people who have been bereaved during this time. And to some extent, the particles that we see here of the COVID virus have been cut off and isolated. And I think this is similar to the isolation that many people who have been bereaved have been experiencing during this time. So I just felt that was a powerful image. So in the presentation today, I'm going to look at grief under, quote, normal circumstances, grief and bereavement specifically during COVID, the multiple losses that have occurred during COVID, which we know can impact on a person's grieving process, identify some risk factors, look specifically at family-centered care and how we as clinicians, particularly those who are having face-to-face contact with patients and families, identify some resources that may be useful for you to have, and very importantly, concluding with self-care. So the significance of COVID on bereavement, and really it has disrupted not only how we live, how we die, but also how we grieve. And the effects are likely to continue ricocheting through society in the foreseeable future. And certainly we're seeing second and even third waves that are happening in Europe. Under normal circumstances, around 44,000 Australians will develop chronic and debilitating mental health impairment, particularly in the form of prolonged grief disorder. And so bereavement, whether attributable to the virus or not, in and itself presents a risk factor. And because of the public health measures that are being implemented during COVID, this I think is something that really deserves our attention. And more broadly within the research environment, little's been known about the mental health effects and support needs of people who have been bereaved during global crises. And this included, for example, the tsunami in Asia, the earthquake in Haiti, etc., where a lot of these studies came from. So I want to start us off with a case study of a patient called Craig, not his real name. Craig was a 57-year-old male, originally from Tonga, and he had an aggressive head and neck cancer. Diagnosed about 12 months ago, he underwent combined chemoradiotherapy, and at that stage with curative intent. However, there was evidence of tumour recurrence a few months after treatment was finished, and he subsequently had palliative chemo and then a PEG tube and a permanent tracheostomy because of the tumour invasion in his neck. Craig came from a large Tongan family, and he had over 50 cousins, aunts, uncles. He was married, had a son and a daughter, and a 7-year-old granddaughter who had autism. And because of the visiting restrictions that had been put in place in the acute hospital, his family decided to opt for a home death. He was transferred to our community palliative care service for ongoing symptom management and possibly end-of-life care. He was at this stage phase 3 RUG5, which meant that he was deteriorating and terminally ill and required 2 people to assist him. So our allied health team, a referral was sent to set up the home with equipment, including a hospital bed, discussions with his family about what would be needed to support him at home, liaison with the GP about the availability of ongoing prescribing and issuing the death certificate. Education, importantly, to his family members to enable them to administer subcut medications. However, 7 days later, he was admitted to the inpatient service due to increasing episodes of bleeding and increasing care needs, and he died 48 hours later. So the inpatient staff had very little time to build rapport with the family, and given that we have restrictions currently of only 2 visitors, only his daughter and son were present when he died. because his wife had gone to Tonga to visit her ailing father, and because of the travel restrictions was unable to come back. His son had worked as a security guard at a music venue, but lost his job during the lockdown and venues were closed. His daughter was having a real challenge trying to homeschool her daughter, who had autism, and there were, of course, a lot of supports in place for her when she was at school. So referrals were made to the multidisciplinary team for emotional support as well as practical advice, given the complexities of the situation. His funeral was a small gathering, again with numbers restricted, and whilst the funeral service was video recorded, family members, his very extended family, could not attend, and to gather in their traditional way to provide comfort and support. And of course, his wife was grieving in Tonga on her own without the support of her family, and the adult children were grieving the death of their father without their mother being present. So let's have a look at some of these issues that this brings up. So firstly, deaths during COVID have occurred against a background of multiple losses. And whilst grief itself is a normal response to a loss and itself a physical risk factor for many physical health problems and psychological distress, along with COVID has come many other losses: loss of routine, loss of freedom, employment, finances, future plans. And so it's been hypothesized that many people really are living in a state of mild but chronic grief as they manage these losses. And we know that secondary losses are likely to complicate normal grief reactions by compounding distress and also removing meaningful activities that could provide respite. And so that's flagging first that lack of social support is a risk factor within bereavement. Some general data on mental health in terms of the impact. There have been over 44,000 funerals that have been conducted, many with physical distancing restrictions. At the peak of all of this, calls to Lifeline were up by 25%. And all of these figures have increased, of course, with the Melbourne outbreak. Beyond Blue saw a 40% increase in calls. Preliminary modelling by the Brain and Mind Centre suggested that the crisis could cause up to 750 extra suicides if the employment rates would go to 11%. And in the very early days of the second wave in Melbourne, there was a report of 32% increase in self-harm among young people. So the next issue is physical distancing, and of course with strict hospital, palliative care and nursing home visitations were restricted, many services having 1 or 2 family members to visit. And this brings with it a lack of opportunity for unfinished business and to say goodbye. There have actually been cases in ICU and of course, as we've heard on the news, in nursing homes where no family members could be present. This brings up another risk factor around lack of reality surrounding the death. And there's been certainly reports coming in of families having concerns about accessing healthcare or fear of the patient getting COVID. We know that many people are not doing their cancer screening because of this. But in terms of palliative care, it may mean that some families have had less interaction with clinicians. I want to look at this issue too of home death versus inpatient because there's been a great change in this, certainly in our service, and we're hearing it in others. There's been an increase, of course, in discharge from the acute hospital to the community due to these visiting restrictions. And we're starting to get reports through of health professionals, nurses, clinicians in the front line, experiencing what's being determined as vicarious trauma and perhaps disenfranchised grief, as families really in the heightened distress express anger at not being able to visit freely. And of course, there's the issue of trying to communicate with patients and families through the depersonalization of protective clothing and through masks and visors, etc. We know in terms of our service that patients dying at home require daily symptoms to ensure daily visits rather, to ensure that symptoms are managed and for the families themselves to feel supported. Looking at our own statistics, and I think this is really quite stark, we find that our inpatients are dying sooner when they come in. Our average length of stay in July last year was 14.5 days. In July this year, it was 4.9. And this has real implications for the care and for the support we can provide because it gives very little time for staff to establish rapport and to undertake the very intense pastoral care and psychosocial support and symptom management that's required in such a short space of time. And this is a graph of our home deaths, which is really interesting. And it shows that in February, we had 4 in the month, which is about our average. But at the peak of our lockdown, around about May or June, we were up to 18. And then as we came out of lockdown and things started to get a bit difficult again, we saw an increase. So this is definitely having an impact. So what are the impacts of particularly people who are isolated and not able to have family members present. Systematic reviews have showed that hospitalised patients who are put in isolation for medical reasons are more likely to experience depression, anxiety, anger, and a loss of self-esteem. It's been found that healthcare providers spend less time with them, and this impacts patient safety. And often there's been a rise in adverse events associated with care. We know just more broadly that loneliness is a risk factor for mental disorders such as depression, anxiety, adjustment disorder, chronic distress, and insomnia. And Harvey Chochinov, more recently in an editorial, referred to the fact that patients who are in isolation are really mirroring his earlier studies that showed that lack of social support, symptom distress, and not feeling valued or respected can undermine their sense of dignity. The risks for families not being present at the death means that they're denied the opportunity to bear witness to the death, to advocate for optimum health care, and of course forego final goodbyes. And not having access to their loved ones can put them at risk for prolonged grief disorder. And of course, this leaves many unanswered questions. Did their loved one receive the best care? Were they in pain? What were they thinking on in those final weeks and days? Was someone with them? So the pandemic has meant that families have foregone a lot of these community rituals of mourning, with restrictions placed around what can occur at the graveside. And this very stark image of socially distanced mourners in April this year in the UK illustrates that. We know that funerals play an important role in the grieving process, providing community support and comfort for the bereaved, and to assist in the processing the reality of the death. And of course, if we're looking back at Craig as a case example, his wife is in Tonga, his extended family unable to be there. And I think we really need to be aware of people who come from culturally and linguistically diverse backgrounds, because they've seen their own communities going through this. We look at those incredibly distressing images that came through from, for example, Italy very early on. And so they have these concerns for vulnerable family members who may be ill or who have died. And so they've been unable to travel overseas again to say goodbye or to participate in various rituals. This is a very good summary, I feel, of the risk factors that are associated with COVID in terms of grief. I've summarised a lot of these, and of course we're looking at limitations that have been brought around by very valid public health restrictions. And of course, for people who have had a COVID death, there's this added level of feeling responsible for the death if they've brought the virus into the household, and of course that isolation when they've been treated in ICU. So why do we need to respond? What can we do? And of course, the medical community and all the media is talking about we need to flatten the COVID curve. However, I believe there's an urgency now for hospitals to get ahead of what I've determined as the bereavement curve. We know from the general literature that poor bereavement outcomes, the risk factors are a history of psychiatric issues, lack of social support, a sudden or traumatic death, lack of preparation for the death. This is certainly a focus during COVID, a hospital-based death, and death in intensive care. ICU particularly has risk factors, and these include the patient dying while intubated, family members not able to say goodbye, and perhaps poor communication between physicians and family. What are families perhaps who are bereaved experiencing during COVID? Certainly intensified feelings of loneliness and grief, natural tensions and resentments difficult to manage, and we certainly see this in the increase of figures in domestic violence, lack of distraction, worried about their community, their society, their family, the economy. And those that are already affected, who have been bereaved, may have had earlier on lack of access to their bereavement care. And there's this general concern about the national crisis, and the figures overseas may give this feeling of lack of empathy, that some losses are less worthy, that their loved one has been reduced to a statistic, and that also they may hesitate to ask for support because people in their own network are preoccupied with their own worries. So what could we have done for Craig's family? Certainly there's the option of telehealth video conferencing. His children in the extended family, his own granddaughter. We certainly allow children to visit at end of life, but there's the option of writing letters, doing drawings, the use of the tablet to communicate with his wife in Tonga and family members. For the relatives who couldn't attend the funeral, of course, there's the option of live stream and online platforms. Encouraging the wider family to set aside some private could buy some time for that, to look at pictures, light a candle, create a digital slideshow, etc. And of course, down the track, and we see this every day when we look in the newspapers, the private memorial service that may happen later. But importantly, to be reminding people that bereavement services are still operating, whether that's face-to-face now with physical distancing or via telephone or teleconferencing. This, I think, brings the focus on family-centred care, because really this physical social distancing being the main mitigation strategy to reduce transmission also impacts on how we deliver care. So therefore, we need to look at family presence being supported in non-physical ways. And there's been quite a lot of strong comment coming out of the States, particularly around these restrictions on visiting, that really they need to be clearly defined and communicated to clinicians, families and patients, so that it's not the frontline staff who have to bear the brunt of giving this information. And that if they're exemptions, they should be adjudicated in a transparent way and an equitable manner, again, to reduce the strain on the clinical team. In terms of family-centred care under COVID, we need to make sure that clinical teams establish a primary family contact. And this may be sort of in addition, you know, the teenage son who knows all the IT stuff and can set it all up for the family and have it ready for them, to document for them the technologies that are available, to identify and address any barriers that may be there, to develop a plan for future clinical updates and what communication platforms are going to be used. And of course, with Professor Joey Clayton's earlier work, the use of a question prompt sheet, encouraging families to list the questions they want to ask. Harvey Chochinov is talking very much of the increased role of the patient dignity question in the time of COVID. And that question is, what do I need to know about you as a person? Not clinically, but what do I need to know about you and your life? And also to suggest activities for the families to do, such as journaling, to try and maximise the efficiency and the coping. There have been evidence-based recommendations, and I really recommend Selman's article, which I've put in the references at the end, to look at early advanced care planning discussions, to have timely, proactive, sensitive information provision, to assign a specific contact person for each patient. And we talk a lot about continuity of care and the importance of that, to follow expert guidance on telecommunication and communication with protective personal equipment. And of course, to bring in specialist palliative care collaboration, referral, advice, and using triage, and of course, optimising symptom management. How am I going for time, Ursula?
Probably just a couple more minutes.
Good, I'm nearly there. Allowing the family where possible to visit a patient who's deteriorating, to facilitate communication, remembering charges. Often patients come in with their phones but not their chargers. They urge in the guidelines to be cautious about virtual communication when the person is actively dying, and to ensure, of course, that there's emotional, psychological support afterwards. There are many resources available that I think can be very useful for us as clinicians, as also families, and I've listed these, and I'm sure the slides will be available for you. The Australian Centre for Loss, Grief and Bereavement have some very good, clear fact sheets. Many of you would be aware of the communities of practice that have been happening in oncology, palliative care. I really recommend that website. It's got excellent resources for supporting bereaved families. We know about webside manner, and I love this terminology, and I really recommend this article. It's similar to bedside manner, and really it's around really good communication, except we need to be much more nuanced in how we prepare people for it, how we continue, how we close the visit. We know there are challenges, and we need to be really aware of the equity issues around availability. The language, the use of I wish, I'm sorry you're going through this. And I really love this last one about placing your hand on your chest as a sign of empathy, leaning into the screen, as I'm doing now, watching the time. There are many evidence-based staff support recommendations. I think what's important is that first one and the last one, that self-care strategies are not enough on their own, and that you really do need leaders and organisations to make professional sources of support available. And that we really need to be aware of our frontline staff who are on high alert, and then as the crisis eases off, that's perhaps when their distress is going to rise. And I'm going to conclude with this really beautiful quote from Rachel Remen. The expectation that we can be immersed in suffering and loss daily and not be affected by it is as unrealistic as expecting to be able to walk through water without getting wet. And so really prioritising workforce wellbeing and resilience is essential to make sure we get through this. We don't know how long it's going to be. I urge you to go to Palliative Care Australia. They've got an excellent self-care plan that you can work through. We know we have access to the employment assistance program as well. So I think that's pretty much me, and I don't want to go any further over time. Thank you.
Thank you so much, Liz. That was just a fantastic overview, and I think such an important topic for us to be thinking about. And I think, you know, we've been caught up in the public health emergency, but I think you've presented a, you know, really important case there for what's to come in terms of bereavement. We do have a couple of moments for questions. If anyone wants to shoot a question through on the chat, or, you know, use the raise hand function, please feel free to do so. I guess while we're waiting to see if there's any questions, I'm curious to hear about your experiences, perhaps just at your centre, with staff morale and support amidst, you know, observing those and kind of supporting such challenging cases.
Yeah, I mean, it was interesting when the whole thing started. There certainly was that heightened level of distress. There was concern in the early days about the availability of PPE, as we know. Setting plans in place in terms of social distancing. We've been urged not to mix teams, obviously limiting our visits. But once we actually got our local health district plan into place, that was a lot easier. We've now, just in the last couple of weeks, been allowed to recommence our mindfulness sessions for staff. We have a daily huddle that we've called it, where staff gather, socially distanced of course, just to report in on the day, how they've been. And this happens when shifts change. So staff coming off night shift, the day shift coming on. It happens in our executive team, and it's really important to be able to see one another, because we're not meeting, you know, in large groups anymore. We've limited the number of people who can be in a room, even who we share our lunch with. And so to be able to have that face-to-face contact is so important. We're obviously doing many more Zooms, as we all are. And there are lots of resources that have been made available to staff, which I sort of, you know, look, we all know they're there, but how many of us go to them? You know, there are so many links that are coming out now from various organisations about self-support and resilience. But I think the key really is that we check in with one another to see how people are going, and to be able to acknowledge that. At the moment, we're really encouraging staff to take leave, because everything's being on hold, because we wanted all hands on deck, not knowing what was going to happen. So take your rostered days off, take your leave, book your holidays, even if you can't go across the Queensland border. So it's really about urging staff to take care of themselves and of one another.
Yeah, so important. And I think, you know, one of the sort of unusual things about this period, I think, has been the sort of global nature of the stressor. You know, the staff have been stressed by essentially the same phenomenon, the same thing that might also be stressing our patients and families, yes, which is just conceptually interesting, I think.
Yes, because they go home to their families, you know, concerned, am I taking infection home with me? You know, our palliative care consultants, we're now seeing them in scrubs. And, you know, just in a way to keep themselves safe and to limit the extent that spread may happen. Yeah.
Brilliant. Well, that was an absolutely wonderful talk. The one sad thing about webinars is that we can't give you the rousing round of applause that you're due, but I'm going to give you the virtual hand clapping signal anyway, and I'm sure everyone would join me in thanking you for that. So
and I'll stop sharing.
Yeah, that's fine. That's fine. Oh, look at all the virtual hand claps you're getting, Liz. That's that's nice. So I've got the pleasure now of moving us on to our next segment, which is going to be the first of our 2 rapid fire sections, which is an awesome chance for us just to hear little snapshots of different studies, you know, hot off the press or, you know, just about to start. So we're going to have 3 7-minute kind of rapid fire talks in this one. So I won't take up too much time other than to welcome the wonderful Professor Ian Olver, who's going to be presenting to us about a fascinating study here, Hopes and Beliefs. Well, I'll let Ian tell us about it, end-of-life decision-making among Indian patients. So welcome, Ian, and thanks.
Thank you very much, Ursula. And this study was done by myself and Jacqueline Elliott Mahadi Chitin. Jacqueline's my colleague at the University of Adelaide. She's in public health. I'm currently in psychology. And we're going to present some unpublished work on hopes and beliefs about end-of-life decision-making among Indian patients. And The first issue is how we got to do this. Well, Jacqueline was doing her PhD years ago in Australia, and we were looking at end-of-life decision-making and using patients with cancer as the group that we wished to gain the information from. And the 7-minute version, if you like, to make it very concise, we found that in general they saw do not resuscitate orders, which was the part of end-of-life decision-making that we were studying. They felt they didn't interfere with the natural death, but this was the sort of decisions about end-of-life treatment that a competent autonomous person could make. When we asked them when they should make that decision or have the discussion, some favoured early in the disease, most favoured a later discussion, but interestingly enough, where they'd claimed autonomy in terms of who made the decision, they felt that the doctor might be best able to discern when it was made. One of the things that we came across, however, was that hope featured prominently in the interviews, and they were using it in all sorts of different ways. But essentially, there was a difference when they used it as a noun or a verb. A noun wasn't as powerful because it was something that could be given or taken away by a doctor giving a prognosis. When it was used as a verb, it was something that people were hoping for, so it was a stronger motivator. And on the question of euthanasia, there were diverse opinions, but mainly it was a hypothetical concept around choice rather than a choice that anyone had actually made. What we wanted to do was to see how these sort of general issues stood up in other cultures, and so we decided to use a maximum difference population. And Mahati Chittum was doing some research work with Phyllis Buteau in Sydney. And so we trained her in the semi-structured interviews that Jacqueline used in the study. And she returned from Sydney to her hometown of Hyderabad in Telangana, which used to be Andhra Pradesh till they split it in half, in India. Now, when you talk about a maximum difference population, if you consider nominally that Australia is a sort of predominantly Christian country, here you've got 2.5% Christian, over half Hindu and 41% Islam, and with a fairly high cancer incidence at 74 per 100,000. So this was the population that she was in her hometown. She approached 85 patients to do 25 interviews, and it was a purposeful sampling, but the reason for the refusal were in fact the family who had the say in whether they thought the patient should respond to questions about life and death, which they don't usually discuss. So the interviews were transcribed using interpretive phenomenology and as a method of analysis. So very briefly in terms of results, all the patients, when we were asking them about do not resuscitate orders, actually interpret them as euthanasia, even when it was clearly explained that we weren't talking about that. They never used the word euthanasia. I think one used mercy killing, but no one used it. But they discussed the thing broadly as if it was in the context of life and death in that way. And in our interviews, two themes emerged. One was a desire for living or dying that was very strongly culturally based. It wasn't based on the same sort of opinions that were being given by our patients back in Adelaide. And the second theme was that God was the ultimate decision maker. So I'm just going to very briefly run through some of the interview quotes that talk about these themes. So the first one is the perception of current family responsibilities. And one patient, as you see there, said 70 years is more than enough to live. Till 50 you're working. After that you get 10 years where you can enjoy your retirement, but now I'm only taking up scarce resources. so there's no point in me living anymore. So I've got cancer. I don't want to have my life prolonged. It's a very strong view, totally outside of the patient's individual sort of autonomy, if you like. The other one was even more interesting. All my desires have been fulfilled. This was a woman. Everything is over. My sons are married. They have children. My husband is a good man. So I want to die. I want to die in front of my husband's eyes. I want to die as a Sansom-Daly. Now, a Sansom-Daly is a revered woman because she has actually looked after her husband and family extremely well. But to reach that status, you've got to actually die before them, which shows that you've sort of, I guess, been self-sacrificing. It's not your life, it's theirs. And this woman wished to achieve that. And so that was her motivation for not wanting a particular treatment towards the end of life. On the other hand, of course, it can be a motivator to actually take other treatment. And this was a young male. My life has to be extended at least one more year for my wife and children. That's my only desire. And basically he had no property. We don't even own our own house. We don't have anybody's cooperation. We're poor. And so he felt a strong sense to provide for his family before he died. And that was his motivation for accepting treatment rather than no further treatment. The other issue that came out in terms of the decision about dying or living was whether they expressed a fighting spirit or actually had despair because of their cancer. And here, I told that as much as possible I may live. I told that I got courage, moral courage, so I'll take any chance, even if there's a 0.001% chance to recover, which is in contradistinction with I'll suffer at home and die there itself. Why should I come into the hospital, have chemotherapy, be made feel sick? These injections, they're all problematic. So I'll just despair at all this and I'll just stop treatment for that reason. And the second major issue was God is the ultimate decision maker. The thing is, it is there to save life. Ultimate authority. The Almighty is there to save or not to save. It's all in his plan. We can't see his plan, but I'm not going to make the decision. What will happen will happen. So this was a fascinating look into another culture. There are profound implications of cultural and religious differences in the way patients will approach end-of-life decision-making. So there's no sense in which there's any one policy meets all. And in fact, that's what our patients told us, even on the issue of whether you tell them early or late. So it makes cross-cultural generalisations when setting policy on things such as end-of-life decision-making problematic, and we've got to do a lot more work in dissecting out what our various cultural groups need so that we can meet their end-of-life needs.
Brilliant work. Thank you so much, Ian. That was fascinating. We'll hold over any questions for the moment, and hopefully we'll have a minute or two after our three talks now. But now it's my pleasure to welcome Dr. Natalie Bradford, who's coming to us from QUT in the Sunshine State. And Natalie will tell us a little bit more about the paediatric section. So we can see your slides, Natalie. That looks great.
Sorry, was having problems with my mute button. Thank you, Ursula, for the invitation to...
Oh, you're muted again, Nat. It's popped off.
Can you hear me now?
Yes, I can. Yeah.
Yeah, sorry, it keeps auto-muting itself. Thank you for having me. Would just like to acknowledge my co-contributors to this project, particularly Stuart Egbert and Anthony Herbert. We're talking today about paediatric palliative care, so I suppose a shift from India over to children, but I think, you know, interestingly, there are some of those same sort of issues, particularly around communication, are present. Sorry, apologies. Having issues with my advancing two screens is tricky. Okay, so we know communication is fundamental to quality healthcare. In fact, so much of our healthcare is delivered just through social interactions and these conversations that we have, whether they're in a consulting room or whether they're in the patient's near the patient's bed. And so this is an area of, I suppose, interaction and communication we've been really interested in. We've had a program of research in this area, specifically exploring communication in paediatric palliative care. And we've undertaken a number of different bodies of work, quite a few systematic reviews, exploratory work, and then we've been recording actual consultations to really look at that real world data and using conversation analysis to pick apart those conversations and really look at what's going on and how different topics are approached, particularly looking at ways that families or clinicians bring up subjects around deterioration, dying and death. And our pilot study really showed that that occurred in both very indirect and direct ways. And that project then led to some successful ARC funding, where we're currently recruiting across Australia in a multi-site project and really hoping to learn more about the different ways that both clinicians and patients and families talk and bring up subjects. So we know that we have a number of resources to support communication, and particularly in adults, we know that we've got clinical practice guidelines that exist to really, I suppose, guide us around how we approach communication. But there aren't any of these types of resources yet for children. Through our work, using some of the evidence that we've developed, looking at those real world consultations, we have developed some communication training resources for clinicians. These are available on CareSearch. But we know that communication is two-way. And when families are telling us that they struggle also with knowing what to ask, of whom and when, it really becomes highlights that we need resources to support families as well as those to support clinicians. This is where the use of prompt lists have been used quite successfully in adults. There's strong evidence to support their use in oncology and palliative care, and also in paediatrics, but not in palliative care. And that evidence shows us that prompt lists empower consumers, promote discussion, improve communication, improve cognitive and psychological outcomes. They're low cost and easy to implement. But we didn't have any available for paediatric palliative care. So this project was set about to develop that. We used a Delphi methodology. We first of all undertook a systematic review to look at the domains and items that might be relevant, drafted some questions based on group discussion, and then we undertook some Delphi rounds with expert clinicians, achieving consensus on the content, interviewed families and got some feedback on that content, wording and language. And one thing they particularly told us is they wanted it to be a discussion prompt list, not a question prompt list. And then we were able to get that final consensus on the wording and endorsement through Palliative Care in Australia and PAPCANS. So the results are 2 booklets. Families also told us that they wanted a separate booklet, particularly for end-of-life care. So the first booklet covers 7 domains with 23 items at understanding palliative care, making decisions, families' concerns, understanding options for maintaining well-being, managing symptoms, resources and support, and understanding choices for location of care. And the second booklet is really around some of those end-of-life care issues. Example items, things like what happens if we change our mind about what we want for our child's care? How can the palliative care team help keep our child engaged in important activities? How can we balance the care of our child's needs with the needs of the rest of the family? or how can the palliative care team support us to talk with our child, their brothers or sisters or others about what is happening. Importantly, a lot of the concepts in this, in our resources, are centred around the family and extending beyond just the immediate family to the wider community, including school. So in summary, we need more resources to support communication in paediatric palliative care. We found the Delphi method to be a really useful approach, particularly involving parents in that approach as well. And that facilitated the design of the prompt list. Our plans are now to implement this and look at its effectiveness widely. The resources are available in hard copy print and also freely available through the palliative care website. I'd like to thank you, and the references that are supporting this work are available there as well. Thanks for having me.
Brilliant. Another fantastic talk. Thank you so much, Natalie. And yeah, I think that's been just really important work. And I don't think we have any urgent questions, but we will be holding over. I get to the fun task of actually introducing myself now. So let me just do that. I'm our last rapid fire person for this segment. So hopefully everyone can see my slides. So yeah, this is a really nice opportunity, and I think so many synergies coming out, you know, across all of our diverse projects. And so as I kind of mentioned up top, I'm a clinical psychologist, and my clinical and research work is really squarely in the world of adolescents and young adults with cancer. And the thing that I find endlessly important and fascinating and moving about working with this group is how sort of strange and weird it is for someone so young to be facing the end of their life. And this quote that I came across a few years back really captured it for me, which is that for a dying adolescent, adolescence is the paradox of emerging capabilities and diminishing possibilities. So the idea that you can have windows opening and closing at the same time. And so for me in the work that I do, really, if we can just help young people to maintain their sense of identity and autonomy and agency amidst that, I think that's a really vital thing to be able to do. So I wanted to briefly give you a snapshot of some of the work I've been doing the past couple of years with my difficult discussions study, which picks up nicely from what Natalie's just talked about, because it's also about how we can support communication with young people and their families. It's been a 3-stage study over a number of years, but I'll be presenting some data from the first phase, which was our multi-perspective evaluation of this particular tool, and then talk about how we're tailoring it to the Australian clinical context. So this work and my inspiration to kind of embark on it really started a number of years ago. As a PhD student back in the day, I was lucky to spend some time training and learning from Dr. Laurie Weiner, who's the head of the paediatric oncology branch at the National Cancer Institute in the US. And some years back, she and her team developed this tool, Voicing My Choices, which was an adaptation of a tool that existed for adults called 5 Wishes. And really, as Laurie would say, this tool is one which is designed for and by adolescents and young adults. So really there were, you know, large groups of young people very much involved in the co-design and the development of the tool. It's not a cancer specific tool, so they undertook these evaluations primarily with cancer and also in HIV. But the purpose of the tool is, I suppose, an advanced care planning guide, but really it's a communication tool designed to help support and guide some of those important conversations that need to happen if a young person won't survive. So I'll give you some snapshots here from the original American tool. So it's got some quite medical sections. So for example, the types of life support treatment I might want or not want, who I want to make my medical care decisions if I can't make them on my own, you know, how I want to be comforted, that concept of sort of comfort care or supportive care, you know, pain management, but also some very kind of psychological, psychosocial and existential and almost kind of legacy making components. For example, you know, how I would like to be able to share my belongings after I died, or how I want to be remembered on particular special days. So I suppose to say, you know, the impetus to do this study was also that working in clinical practice, I was aware that there were a number of clinicians, myself included, around Australia who were using this tool already with Australian young people with incurable cancer. And so the question was really, well, do we know that's appropriate? We don't necessarily have data to support that, so let's do that study and find that out. So what I'll be presenting here was the first phase of that research, and really it was a multidisciplinary approach, a multi-perspective approach rather, and so we included 28 healthcare professionals from both paediatric and adult sectors, but who worked with adolescents and young adults with cancer. Most estimated they'd cared for at least 15 who died from cancer, pretty even split between, you know, oncologists, hematologists, allied health and nursing, but on average they'd worked for at least 17 years in AYA oncology. Our young person and parent group involved 10 cancer survivors, 3 parents of AYA survivors, and also 2 bereaved parents. On average, our survivors were about 22 years old, a range and a mix of cancer types. 40% identified that their cancer type was an intermediate or a high risk. So one of the primary aims of in the first stage of the study was establishing its appropriateness. And we did this in the interview by a page-by-page approach because the sections were quite different. But overall, across all of those different groups, the appropriateness was quite high, average 4.1 out of 5. But we did see a bit of nuance across the different sections and also across the groups who were reporting to us. The AYA's, the average acceptability was also pretty high, and this quote was quite nice. This young person said, and this would have been a survivor, every person should get the option to have this. I didn't get anything like this given to me whatsoever. I think they thought I couldn't take it, but I could take it. Parents, the average acceptability was a little bit lower, which, you know, perhaps those of us in clinical practice, and I noticed there's been some chat in the chat about the gatekeeping of families. I think that's maybe no surprise that parents can be a little bit more concerned and cautious about these conversations. And the health professionals were very sort of generally enthusiastic about the tool, and think, you know, this quote saying, I think it starts a lot of great conversations. I think often these are probably things that have at least passed through the young person's mind, and so giving them a place to actually explore that a bit more, this is great in guiding the young person with their thoughts and plans and wishes for the future. So this is very much just a snapshot of the data, which we'll be sort of publishing in the coming year, hopefully. But so this took us to the second phase, and the other objective of that first stage of interviews was not just to kind of evaluate the acceptability and the feasibility, but actually also to gain feedback on how could we improve this tool, tailor this tool to make it even better and even more suitable for the Australian clinical context. And so in this second phase, we embarked on cognitive or think aloud interviews, stepping the young people through, you know, the different changes that we'd made. And so what we were able to do was to create a sort of mocked up version with, you know, the changes that we'd made to the tool. Some of those were real just wording changes. We think we're speaking the same language, American English to Australian English, but there are nuanced differences there in terms of how we talk and how we kind of speak and read. And there are also conceptual differences as well. So for example, we probably wouldn't think about asking or giving an AYA the choice to hire and fire a healthcare professional if they didn't like them, but that was something that was in the American tool, and so things like that we edited, and also just great ideas that they had about things that were missing that they could add in. And so we did 17 of those interviews as well. And some of this process around adapting the tool is stuff that we were able to write up about, also considering colleagues following similar processes, adapting the tool in Brazil and in Brazilian Portuguese. So I think it's just interesting thinking about the linguistic and the cultural adaptation, even just from American to Australian English. One of the things that's an ongoing piece of work, and this speaks to some of the feedback that we got across those 2 stages of interviews, was also, unsurprisingly for AYAs, they had some really strong thoughts on the graphic design of the tool and whether they liked it or not. And the feedback was a bit mixed, but you know, some of them felt really strongly that they didn't like it, that, you know, this idea that it was forced nature imagery, or that it was a bit unnatural, helter-skelter, and I wouldn't think much of it. Some of them thought it was okay, it was pretty relaxing, or they liked the dragonflies, but some just thought a bit mixed, a bit dated. But all up, I suppose, as part of this idea of making it a tool that young Australians really embrace, we're currently embarking on a stage of, you know, giving it a bit of a graphic design update or refresh, that's something a little bit more, you know, fitting for the Australian context. So that's been just a real mini taste of what we've been doing looking at this tool, but essentially what we're finding is the Voicing My Choices tool does appear to be appropriate for use with Australian AYAs, but does need some cultural adaptation. And the next steps, really, we're getting it graphically designed, and then really excitingly, we'll be piloting the new tool with AYAs who are currently undergoing cancer treatment. So in that next step, to take it into clinical practice. And we've got a range of sites in Sydney, Melbourne and Brisbane who we're going to be collaborating with to do that. So thank you all for your time. I welcome anyone to reach out to me, email or Twitter anytime to discuss more. And also just really want to thank all of our funders over the years who have made this work possible. So I might stop sharing the slides there because I also get the chance to wrap up that section. And just, we do have a few minutes. So if there are any questions for any of those last 3 talks, yeah, shoot them through the chat or raise your hand or just unmute yourself and go for it. Any questions? Well, otherwise I might have a question for Natalie about her talk. Natalie, I love the idea of recording the consultations, and I find that conversation analysis approach so fascinating. I'm just wondering how you went, I guess, convincing the clinicians, or whether you ever had any pushback on that. I know you work with Anthony, who's a wonderful advocate and, you know, very passionate about the research. So I'm sure he probably was very happy to volunteer himself for that. But I just wondered about other clinicians on the team, whether there was any pushback or nervousness about actually recording what they were saying.
Absolutely, yeah. So and the project is recruiting, you know, across a number of different palliative care services in Australia, and clinicians are really concerned about the idea of being recorded and that concept that maybe you're going to be judged, or you know, that the way that you've delivered a consultation is going to be, you know, really scrutinized. And so our approach is very much to I suppose, reassure people and refocus that the purpose of the recording is not to make any judgments about the content of the consultation, but it's really to look at the different ways that communication has occurred. For instance, who may have started a particular topic, and some really interesting things, even, you know, eye movement. Stuart's currently got a PhD who is looking completely at eye blinking and how a parent pulls back and closes their eyes when they're discussing something that's difficult. So when we talk to clinicians about, you know, what it is that we're actually looking for, they're somewhat reassured by that. There are still clinicians who don't want to be recorded, and of course that's absolutely their right. So our recruitment strategies are to, first of all, I suppose, identify who may be involved in different consultations. We obtain clinicians' consent first before we go to approach any families. Families are, on the other hand, are actually quite happy to have consultations recorded when it's framed that the purpose of it is to understand communication and to look at the different ways that we can support and develop resources around that area.
Yeah, that's brilliant. And I think that framing sounds like it makes a lot of sense to get those people on board. Brilliant. Well, I think we might keep going then in the interest of time, and to make sure that all our speakers get a chance of having questions as well. So I'm thrilled to welcome our next batch of rapid fire superstars. I'm now going to welcome Dr. Lahira Russell, who is going to be speaking to us from Deakin down in Melbourne, or probably not from Deakin, but she's at Deakin. And Lahira, yeah, welcome to share your screen. Thank you for joining.
Lahira, you're muted.
Sorry, I was on mute and I couldn't unmute, so I had to stop sharing, and I'm going to start sharing again. Apologies for this.
Oh, good.
How are we going here? Is this better?
Yep, and then you can just click to enter your slideshow if you want to do that. Yep.
Yes. So I think here we are. Are we all good? Can we all see this?
Yep.
Perfect. Thank you.
All good.
So thanks. Thank you everyone for the opportunity to present today. And it's a little bit of a change of gear in terms of the project I'm going to present today. But before I get into it, I'll just briefly acknowledge people who are supporting and in the team: Julie Considine, my supervisor, but Claire Johnson as well, who's now moved to New South Wales, but there's also Marianne Street-Berry and Liz Fleming, who's a consumer representative in our team as well. And as to who I am, I'm just a research fellow who sits in the Centre for Quality and Patient Safety Research at Deakin Uni, but my role also sits within a partnership between Deakin and Eastern Health, where the study is being conducted. So in this presentation, I'm going to talk more about what is documented actually in clinical practice, and what we're doing is we're looking through the medical records of patients who've actually died at Eastern Health and who've been diagnosed with cancer. This study is very much framed around the National Consensus Statement on End-of-Life Care, and obviously, as you will all know, that it clearly acknowledged that safe and quality care involves respecting patients, people's wishes and choices about health and clinical care, especially through their illness trajectory and at the end of their life. These national guidelines also recommend that the conversation about end-of-life care in acute health services occur when a life-limiting condition such as cancer is diagnosed, and to ensure that this high-quality care is provided in these settings and that they align with the patient's value and preferences. Well, clinicians are expected to proactively engage in those discussions with people who have a diagnosis such as cancer, or who they know that prognosis, they have poor prognosis. But we also know that there are a lot of barriers for optimal end-of-life care provision in acute settings, and broadly speaking, assumptions about death and dying, and also about the person's and the family's wishes could be misaligned, and that could increase misunderstanding and deviation from patient-centered care. Also, we know that discussions about end-of-life care between patients, but also family members and health professions, are often poorly documented or not documented at all. Well, and this can, as we know, can have a negative consequence on the quality of the care provided, especially if a person is unable to make or communicate their care preferences or appoint a decision maker when they become too ill. So really this lack of, as we know, also this lack of understanding of a person which wishes can result in many negative consequences, such as unnecessary treatment, loss of dignity, or additional distress for the patient, but also family members and health professionals. So for all those reasons, it's important that documented end-of-life care preferences that are also readily accessible in medical records are clearly stated to support the provision of optimal care. A little bit of Eastern Health in this setting. So following the National Statement recommendation in July 2015, Eastern Health has developed its own standards to guide the delivery of end-of-life care. So staff training and performance measures were put in place to ensure that end-of-life care is provided in an effective, coordinated, timely, and culturally sensitive manner. The guidelines and standards supporting end-of-life care at Eastern Health include the ones that you see here: advanced care planning, resuscitation planning, goals of care in complex cases, care of the dying, grief and bereavement care. But at this stage, it's we don't really know the extent to which these end-of-life care discussions are documented according to those standards. So that leads to the premise of this current projects. And this project mainly focuses on people with cancer. Cancer is commonly has a distinct trajectory of functional decline and predictable death. So a cancer diagnosis, especially if at advanced stage, may be an opportune time to engage in end-of-life care discussion to support optimal care provision. So the aim of this study was really to explore the content of end-of-life care discussions that are documented in patients with the cancer diagnosis who have died at Eastern Health. And we are also going to look on secondary aim is also to look at potential differences of documenting these discussions according to patient's country of birth, language spoken at home, and religion. We are using a cross-sectional, retrospective cross-sectional design to explore the content of these documentations. The study will be conducted across all 7 Eastern Health sites. And we're actually collecting data in 2019 because, well, it will be a more accurate reflection of what has happened until COVID hit. And then we'll potentially go and look into what happened in 2020 and beyond to see if there is a, how things are evolving since then. Data, as I said, are collected through medical records, and we're developing an electronic data collection tool using REDCap, and we'll be collecting patient and clinical characteristics, but also patterns of admission. At the moment, we're thinking in the 3 months leading before death, and we're also collecting the presence of absence of those standards recorded, standards of end-of-life care. So evaluating these documentations will help us identify areas that are performed well, areas where improvement are needed, and areas that relate to, well, and these improvements, whether they're related to practice or training. Well, like I said, this study will also help us evaluate whether there is a difference between people's backgrounds based on the country of birth, language spoken at home, and religion. But also need to highlight that the understanding of this process will be limited by the fact that we're collecting documented information. So this project will provide one side of the puzzle, of the big puzzle, and hopefully it will be the data that we collect will help us design a broader study, inform how we can conduct study going forward. And that's it.
Great.
Thank you.
Thank you so much, Lahira. That was fantastic and important work to see actually what's happening on the ground as well, or what's being documented of what's happening, I suppose. We'll move straight on, I think, to welcome Baby Fu, who comes to us from the University of Sydney, or that's her affiliation. Baby, if you want to share your slides, and welcome.
Thank you very much, Ursula. Can everyone see my screen? Yep, great. Yep. I'll just pop on the slideshow. And okay, so hi everyone, it's great to be sharing my research with you all today, and I'd like to thank the special interest group leads and organisers, so Liz, Ursula and Bonnie, for the opportunity. And just a really quick introduction, my name is Baby and I recently commenced my PhD at Sydney Uni under the supervision of Professor Louise Sharp, Professor Josephine Clayton and Dr. Michelle Weeks. I'm also completing my clinical psychology registrar program and have worked in a number of settings, including drug and alcohol, gambling, and at a university counselling service. So today I'll be providing an overview of my PhD, which hopefully will spark some ideas and collaborations. And for the ease of presenting, I'll be using the terms end-of-life care and palliative care interchangeably. All right, so what is my research about? Well, firstly, my PhD aims to investigate the role of psychologists in specialist and generalist end-of-life care settings and to examine their needs in working in such settings. The idea for this PhD came about following my master's thesis in 2018, which examined palliative care staff's experiences of talking to people with intellectual disability about their dying and death. And what became apparent to me through this research was the valuable role that psychologists can play in addressing some of the gaps in end-of-life care. And secondly, we aim to explore the factors that impact clinical practice, such as death anxiety among psychologists. There has been some research on death anxiety among doctors and nurses, but none to date have focused on death anxiety among psychs. And of course, while we're trained and have expertise in, sorry, I skipped a few slides there, come back to that. So while psychologists have expertise in mental health and human behavior, we're certainly not immune to experiencing issues such as anxiety and burnout throughout our careers. So why the focus on psychologists? Well, according to the Australian Psychological Society, psychology has much to contribute to understanding issues of death and dying from the perspectives of theory, research, and practice. I've also outlined here 4 other key reasons. So while dying and death is an unavoidable part of our human experience, living with a terminal illness can be stressful for the person and their loved ones as they experience physical and psychological challenges such as bodily changes, pain, and mood disturbance. And we know that the comorbidity of medical and psychiatric pathologies can negatively affect disease progression, quality of life, and overall health outcomes. Psychologists can facilitate patients' adjustment to illness and help alleviate psychological distress. They're also able to assess, treat, and manage psychological disorders and mental competence at end of life, support the decision-making process for the patient and their carers, offer support to other members of the team, and contribute to best practice and policy development. Secondly, psychologists remain underutilised and underrepresented in end-of-life care. Based on a 2010 audit of palliative cancer care in Australia, there is on average a 0.15 FTE of psych staff working in palliative care. This low level of involvement of psychologists could be due to limited resources in public health, and patients may be referred to psychologists in private practice as a result. What we also know is that there is limited information on the current role and needs of psychs in end-of-life care. In our work, we'll be examining the similarities and differences between various contexts and settings. We hope that our research will go a long way in enhancing psychological care and treatment at end of life, aligning with the 2018 National Palliative Care Standards, which highlights the importance of identifying improvements in service provision. And thirdly, the role of psychologists in palliative care is not well established and defined. Evidence suggests that there is significant variation in psychologists' roles within palliative care teams, with roles determined following negotiation with other team members and potentially blurred across allied health professionals relative to other care contexts. A clearer scope of psychologists' involvement can help guide the structure and recruitment into end-of-life care teams in future. And lastly, recent studies indicate that death anxiety can lead to greater difficulty with end-of-life communication and decision-making among doctors. Psychologists may themselves experience death anxiety, potentially affecting their work with clients. What views do they hold about dying and death, and are they adequately prepared to work in end-of-life care? These are just some of the questions that will be addressed in this PhD. So there'll be 4 main stages in this research, starting with a systematic lit review, which seeks to document the scope of work undertaken by psychologists, their needs to be able to work well within this context, as well as the facilitators and barriers to working in end-of-life care. The second stage will focus on interviews with healthcare professionals in end-of-life care, such as GPs, nurses, community-based and specialist palliative care team members. These interviews will explore the role and need, if any, for psychologists and their views on the facilitators and barriers to the involvement of psychs. Similarly, we'll interview psychologists with and without experience in end-of-life care to allow for a comparison between groups. These interviews will inform the development of a wider survey of psychologists. And a major component of this survey will measure death anxiety and its impact on clinical practice. We hope to identify the predictors and moderators of psychologists' perceived ability to work with end-of-life issues, such as the relationship between specific items on a death anxiety scale and their perceived level of confidence. These results will then inform the fourth stage of the PhD, which could include a preliminary evaluation of an intervention for psychologists or a review of formal education and training curriculum for psychologists. And we hope that these important insights will help develop strategies to promote the engagement of psychs in end-of-life care and to contribute to the upskilling and training of the psychology profession, and hopefully go some way in addressing or contributing to calls for palliative psychology as a specialty. Our work should also align nicely with current research on death literacy and death competence amongst healthcare professionals. So this brings me to the end of my presentation. Thank you all for listening. I certainly welcome any feedback, comments, and ideas, and would love to hear from you. So thank you all again.
Brilliant. That's a great body of work ahead of you, baby. Thanks so much for talking to us about that. And it's now my pleasure to welcome our last rapid fire speaker, Madeleine Yeoman, who's also a PhD candidate at Sydney Uni, I believe, who's going to be talking to us about paramedics and palliative and end-of-life care. So welcome to share your screen, Madeleine.
Oh, hi there. Sorry, I'm just sharing my screen now. Oh. Okay, great. So thanks for the introduction, Ursula. And my name is Madeleine Yeoman. I am a PhD candidate at the Northern Clinical School, where I'm investigating the role of paramedics delivering palliative and end-of-life care in the Australian community, under the supervision of Professor Josephine Clayton and Professor Phyllis Bitteau. So I have a background in paramedicine, and more recently I've been working in public health and palliative care policy and research. These combined experiences have ultimately compelled me to undertake a PhD in this field. So broadening the role of paramedics to deliver evidence-based and best practice palliative care will address a major clinical workforce and service issue across Australia. So as our population continues to age, the demand for home-based deaths and palliative care services is rapidly increasing. However, despite most of us wanting to die at home, only 14% of Australians currently have that wish granted. Comparatively, 54% of people die in hospitals and 32% in residential aged care facilities. Palliative Care Australia summarised the economic benefits of home-based palliative care and end-of-life care in 2020, noting when people die at home, major savings usually accrue from their reduced use of hospitals and residential aged care. According to 2017 figures, when palliative care is provided in the community, those recipients are 87.5% more likely to die at home. So one interface capable of improving the statistics to better reflect community preferences is paramedicine. Paramedics are a unique workforce in Australia, attending to patients in their homes 24 hours a day, 7 days a week in the case of an emergency. However, their scope of practice has traditionally been limited to providing life-sustaining interventions for acute emergencies. GPs, community nurses, and specialist palliative care services may not always be available to visit a palliative care patient at short notice as part of a rapid response to an emerging clinical situation, especially after hours. The default in this situation is often to call an ambulance, resulting in the patient being transferred to hospital. However, for patients who have a progressive life-limiting condition, an acute hospital admission may not be what they wanted or the best setting to deliver appropriate palliative care. A 2019 study investigating the incidence and nature of palliative care cases being attended by Australian paramedics highlighted their significant role in caring for these patients. However, the study noted over 70% of palliative care patients were transported to hospital, 99% following administration of pain relief. This is a very common requirement in paramedic clinical practice guidelines in my experience. When you treat, you must transfer. Another Australian study exploring paramedics' knowledge and attitudes towards their role in delivering palliative care revealed significant gaps in clinical competence and comprehension of relevant health law. Research from the United Kingdom mirrored similar issues, where paramedics reported minimal education in palliative care, especially around end-of-life treatment. So in order to improve paramedics' delivery of palliative and end-of-life care and reduce hospital-based deaths, ambulance services systems of care need to be better integrated with GPs and community-based palliative care services. Furthermore, palliative and end-of-life care must be included within a paramedic scope of practice. Currently, all Australian ambulance services have clinical practice guidelines that address pain and nausea. However, not all jurisdictions have palliative care specific CPGs to facilitate a palliative approach to care. My PhD aims to complement existing research in the field while addressing a gap in clinical practice guidelines. I will employ a policy lens to examine the perceived enablers and barriers of good practice for paramedics delivering end-of-life care in the community-based settings. So my PhD project will be a mixed methods exploration into the role of paramedics delivering palliative and end-of-life care in a community setting. I am currently undertaking a targeted systematic integrative review, aiming to be complete by the end of this year. A policy review will follow, which will involve a content analysis of all existing Australian ambulance service clinical practice guidelines related to palliative and end-of-life care. Comparable international ambulance services clinical practice guidelines will then also be reviewed. This process will help to inform the subsequent study, ensuring current models of Australian and international practice are comprehensively understood before undertaking the mixed method study. The mixed method study will examine paramedics and other key stakeholders' perspectives and experience of the role paramedics play in delivering palliative and end-of-life care in the community. Stakeholders to be interviewed will include paramedics, GPs, palliative care nurses and physicians, patients, family members, and policymakers. A quantitative survey will follow to indicate the prevalence of experiences and perspectives shared during the qualitative process. Each of these studies will contribute to a growing body of evidence to be translated into a best practice palliative and end-of-life care ambulance protocol, suitable for piloting and national implementation as my final study. And so the research generated from this PhD aims to better inform Australian ambulances services clinical practice and improve outcomes for patients requiring or preferring a palliative approach to their care in alignment with the Palliative Care National Strategy of 2018. In developing an evidence-based clinical protocol ready for national implementation, I hope to enhance out-of-hours ambulance services, provision of palliative and end-of-life care, reduce avoidable hospital admissions, facilitate more home-based deaths, and ultimately improve end-of-life care for patients with life-limiting illnesses. So thanks for listening today, and here's my contact if anyone would like to get in touch. Very keen to hear thoughts and opportunities to collaborate. Thank you.
That's brilliant. Thank you so much, Madeline. I must admit, I had never thought about paramedics really in this context before, so that's fantastic to be thinking, you know, outside the box about the different ways that we could adapt and extend this work to different disciplines. So that's fantastic, and a nice lead on from Baby's work looking at psychologists. So lots of virtual round of applauses going on. So we've now got just about 6 minutes before the hour to have a few final questions if anyone has some burning questions. Yeah, Liz has her hand up.
I have a question for both Madeline and for Baby. First to Madeline, I'm wondering if you could comment whether the introduction of ambulance care plans have influenced the role of the paramedic.
Yeah, thanks for your question, Liz. So my clinical experience was in South Australia, where the authorised palliative care plans do not exist. And I can confirm that they are an initiative of New South Wales Ambulance, and they do not occur in any other jurisdiction. However, I have had many conversations with New South Wales Ambulance about this, and they have reported to good effect their efficacy in allowing or facilitating goals of care to be established, and also allowing people to have more home-based deaths.
That's great. I mean, I was asking because we've just finished a study where we've reviewed 100 deaths of patients who had an ambulance care plan. So perhaps we can talk about some of that off screen.
Would love to. Thank you.
Thank you. And my question to Baby, I saw a presentation on death anxiety. I think it was at IPOS when it was in Hong Kong. And it was a really interesting presentation. And I'm just wondering, the theory that was used to look at this was terror management theory. And I'm wondering if this is something you'd thought about for your thesis.
No, I haven't just yet, but thank you for introducing that to me. There's certainly quite, death anxiety is growing, but certainly it's receiving a lot more attention now, and I'll certainly look into that. So thank you for that suggestion.
Just a thought, and when I read it, I actually contacted the author who developed it, oddly enough. He was a very old man, and he replied almost immediately by email, and he said he doesn't think it's been used that much in palliative care. So I thought that would be something interesting to have a look at. Just keep in mind. Yeah.
Excellent. Thanks very much, Liz.
Definitely. Just while everyone's thinking about any more questions that they might have, I suppose I might just remind everyone, I'm not sure if everyone's on the line is a member of our PoCoG End of Life Special Interest group, but please, if you're not a member, we would absolutely welcome you to join. We'll probably be having more events like this in the future, and certainly be connecting as a group to facilitate collaborations and connections. So, you know, you'd be welcome to email myself or Liz or Bonnie as well to facilitate that as well. Some lovely positive feedback coming through on the chat to all of those last presentations as well. Any final questions for our speakers? No. All right, well, in the interests of, you know, I know everyone's got a lot of back-to-back Zoom meetings these days. I won't ask another question which will embark us on a further interesting digression. But I just want to thank everyone for coming along today, particularly thanking all of our speakers for setting aside the time, particularly Professor Liz Lobb, Professor Olva, Natalie, Lahiru, Baby and Madeline. Fabulous, really exciting work being done, and sort of feels like a treat to be getting to hear about some of these things before they're even collecting data. So I think really for the purpose of our special interest group, what we'd love to see is, you know, if you've seen something, heard something that is up your alley or aligns with work that you're also doing, please, I think, you know, we would love to see people reaching out and connecting so that we can have more collaborations happening to just really strengthen the quality and the reach of this work, because we know it's important work, but it's tricky work to do, and it's you know, it takes time and effort to do it well. So I think the better our collaborations, yeah, the better for the quality of the work. So please do reach out, and enjoy the rest of your afternoons, everyone.
Thanks very much. Thank you, Bonnie, for organising,
Bonnie,
and everyone for attending. Okay.
Thank you.
Bye.